So, okay, my name is Mo. You just call me Mo. Actually, I'm from 100 km from here. Yeah, it's Hospital NGN Usaha and also Guam. I'm actually very proud of my hospital because my hospital has the longest name in KKM. It's because Cameron wants to fight with us, but they don't have the NJ, the only hospital inside. So, alright, so we are one fine day, Dr. Arif called me out and said, "No, can you give this topic?" Because actually, this topic is actually very close to my heart. Because I'm a orthopedic surgeon and doing MBS. MBS is metabolic bariatric surgery. So the issue with sustaining weight loss is a big issue. I'll tell you after this lecture. So disclosure, I have no conflict of interest. And yeah, this is my hospital. Right? Small hospital. Yeah. So today I'm just going to tell you what is MBS, then about the therapeutic usage, right? The medication usage, even before and after surgery. That is certain purposes for the medication. Right? What medication I'm talking about is the obesity medication, OMM. Okay, what is metabolic surgery? I understand that actually I might be the only surgeon in this room. so I will have to tell you guys the most effective treatment for obesity is still MBS, right? And the most common MBS done in the world, this according to IPSO, is sleeve gastrectomy. Even I myself am doing sleeve, but actually I'm doing sleeve last rather than sleeve gastrectomy. The principle of weight loss in the perspective of a surgeon is that there are three things we have to look at. It's not only surgery, even though I like to think like that, but the most important thing is actually the nutrition diet. I like Prof. Rohana's, just now she said she is a proponent of low carbs. I am a low carbs plus high protein. Alright. And of course, exercises. Just now I wondered if you guys noticed that from Prof. Rohana's lecture there is energy expenditure, right? The NET, right? And you must understand that exercise is only comprises at 5% of your energy expenditure. 70% of it is actually from the BMR, your basal metabolic rate. And basal metabolic rate, it will reduce when you age, right? Yeah, so everybody humble. Yeah. And the one that spend the most energy is so the most and the one that spend the most energy is actually your basal metabolic rate, right? And it's actually the smaller you are, actually your BMI is actually higher, but also if you are younger, right? So you must understand, once the patient has a lot of fat mass, their BMI is low, right? So is it very important for exercise? Yes, it's important part, even though it's only 5%. But the exercise we are looking at is not the biceps or the triceps. It's actually more of the core muscles. So back in club, I have my physiotherapists who then have the structures to do the exercise for all these patients. And of course, lastly, is me. Yeah, MBS, right? So come to me, I will just ask you one question. You want to chop or don't want to chop? You want to chop, CBET medical. So you must understand this. There are a lot of types of metabolic bariatric surgery. In Malaysia itself, we are not in infancy, we are in pregnancy. We are not even infant, right? Because it's like less than 50 years. But there has been documented 5,000 cases, 5,000 types of MBS to be done. Then if you look at this one, some of it is very obsolete. Then some of it is still be using. Even though the gold standard of MBS is still Roux and White, gastric bypass, RIT, but if you look at me, actually I don't really agree. Okay, even though it's a gold standard. Gold standard means it's easy to do, doesn't mean it's effective. And the important terms for the MBS is you, in order, what I'm going to tell you later, is there are three terms: satiation, satiety, and also hunger. Satiation in Bahasa Melayu is kenyang, right? So the maximum volume that you can tolerate after, because this is a research on they say the quick nutrient meal, right? So that's satiation. So you must have also have satiety. Satiety is the feeling of fullness in between meals. Maksudnya in Malay is puas, right? I rasa puas. Then you don't really feel want to eat, right? Food don't come to your mind. Okay, so things like that, right? And also hunger, yes. Hunger is a discomfort, feeling of discomfort due to lack of food, right? So what we notice is hunger is actually it's a hormone response as well. It's a hormonal response. The most famous hormone is actually ghrelin. I'm going to tell you about this later. And because the way I do the surgery is more of hormones re-regulation. So I'm following this hindgut and foregut theory. So you must understand this: the gut, we actually do have producing hormones. How many hormones? There are thousands of hormones, but there are a few hormones that we know that is from the foregut and the hindgut. And because I'm a surgeon, right, we are simple-minded, right? So very easy. Foregut, you fikir tentang ghrelin. Hindgut is a famous GLP-1, right? So those are the hormones that we are talking about. Last time they call it incretins. Yeah. So the pathophysiology of the MBS is that there are changes of these hormones after the MBS. Let's say this is before surgery. You can see that this one, the blue color and the yellow color, the red color is supposedly to be the hormones, the gut hormones. Let's say the blue color, I would say that it's ghrelin, right? Then the red color is the GLP-1. And let's say after RYGP, right? After the gastric bypass, it actually reduces the ghrelin. Ghrelin is to promote hunger, so you don't feel hungry. But because of the transit time going into the distal ileum, the GLP-1 is increased. GLP-1 actually gives you the feeling of satiety. So you're not hungry, you don't want to eat, so you don't eat. But you don't really until become Gandhi, right? You don't want to be so sarcastic, right? So this is what I do. The newer one procedure, what I'll do is sleeve gastrectomy and proximal dental bypass, in which I take out 70% of the stomach. So it means 70% of the grading is taken out. Is plus minus now. Okay, as reminded, right? Of course, there are a lot of things going on behind that, and I will shorten the small bowel, right? I did a research in Taiwan that the average Taiwanese out of the sample of 800. So the average Taiwanese intestine is about 4 meters to 10 meters. So what we do notice, if let's say the bowel length is 5 meters, we try to shorten it to 300 centimeters, 300 centimeters or 3 meters. It will actually increases the satiety. But this is just a crude retrospective study that I get from the data of the intraoperative studies, right? But it would be nice if we can take the GLP hormone. So there are people are doing that, but they did on ghrelin, not GLP-1, right? So, okay, as I said, from my perspective, I take out like 2 sleeves, actually not to reduce the volume, but to take out the ghrelin. So that's why there's hunger. So I bypass the intestine. So I increase the GLP, so more satiety. Less hunger, more satiety. So the patient won't eat lah, won't eat so much, but not until become toxic, right? So the main issues, there are a lot of issues. There are a lot of issues like surgical complication, VT, lead, right, and all this. We are not talking about it because that one, if you are going to do an MDF, your complication rate must be less. How less? Must be at least less than 2% of each and every surgical complication. But since we have really reduced so much complication, but the new thing emerges is the weight regain. This is a very big issue because when the weight regain, the problem is patient unable to go for follow-up so long. You see, right? So, but this weight regain usually it will come back after 18 months. Some actually go up to 2 years, 3 years. The patient won't come to you. You know why? After 6 months, that didn't mean by July, right? So I'm really healthy. No, the patient is really healthy, right? The patient is really healthy. Even let's say, like just now there was a question saying that asking about the diabetes remission is really remission. It's really they do not need any medication. We can off everything, even the metabolic syndrome, but we can off everything. The problem is patient want to come back, right? But the thing is weight regain. Why weight regain will happen, right? So even there are a lot of studies have been done on this, but we have two terms here. One is the suboptimal clinical response, in which the patient actually never really go back to the healthy BMI, right? Do you think after MDS BMI can go to 23, 80? Boleh tak? They are like BMI 35, you know. No lah, I'm not so idealistic lah. You give me 25 is actually enough, alright. But the one thing is, their clinical response is not that as great. So there is a definition. We say that total weight loss is less than 20%, right, of the overall. Let's say it's 100 kg, they always around 90, 80, 90, 80. Usually, his suboptimal clinical response is technical issue. Means the way they do the surgery, maybe the selection of the procedure, right? And the late clinical deterioration, the patient really reduced, really achieved, but came up. The weight regain back. So it is like recurrent weight gain, and it can be in more than 30% of the initial weight loss. Remember the set point theory on obesity, right? It is like that. It is like the human body is trying to conserve energy for you, right? So once you have lose so much weight, the energy panic, your body panic. So what your body trying to do now is try to conserve more fat. So this is where things climb up. When we climb up, it climb up with vengeance. Right? Let's say the initial BMI is 35, it might go to 36, 37. Which is quite helpful, right? So the reasons for it, we seriously don't really know. But what our hypothesis is, weight regain might be neurohormonal mediated, and the long-term data on the gut hormones correlation are still lacking because of that, and the data is still conflicting. There are a lot of hormones, but the three musketeers is this one: ghrelin, BYY, and GLP-1, right? But the weight regain might be related to developmental changes, right? Like age-related, the BMI, because your age is higher, the BMI is lower, maybe pregnancy, maybe menopause, and of course drugs. So when the patient comes to me post-op, this is what I'm talking about post-op patient. Let's say post-op, then let's say the patient still have weight regain. The notorious drugs is the psychiatric drugs. Psychiatric drugs is very notorious, it's very, very notorious. Right. So, and surprise, the obese patient, but not obese patient, the patient living with obesity, alright, okay, they are actually higher risk of psychiatric issue. Usually it's anxiety and depression. So, and endocrine agents like the steroids, right, the hormone contraceptive, and the diabetic agents. Right, all these we must look back at the medication, and we can ask our friend, our medical friend, can this be changed or can it be taken out, right? And obesity management medication are these, right? Actually, for me, these medication are too much for me, right? I have a simple-minded only. I use the 3 medication only. Okay, later you will know which one, right? And you can select the OMM based on the phenotypes. Just now, Prof. Hana, I will show you this slide as well. But hunger is actually we have 4 hungers, but to me is you can go back to 2 actually, right? Which are physiological hunger, and also hedonic hunger. If let's say physiological hunger is like you're really into hormones, like this is post-op patient. So if post-op patient, I'm supposingly I have already taken out already. So you shouldn't have any physiological hunger if the surgery is done right. Okay? And the rest is hedonic hunger. So in the hedonic hunger, who are the one who is going to control this? This is the craving, the binge eating. Right? They are outside. Contract, right? So pharmacological therapy after surgery is actually not new. There's a lot of studies have been done, and one of the better study is this Gravita study. They use liraglutide treatment with persistent or recurrent type 2 diabetes after metabolic surgery. But this is 2019, quite old already, but because this is RCT and double-blinded, that's why I like this. So what they do is they look at the total weight loss. If the total weight loss is the blue line is the one, let's say they already see already the total weight loss is not up to the target, which is 20%, right? So they will start the liraglutide, right? So they start liraglutide, the red color is the liraglutide. So you can see it's a bit coming down, right? And of course, all these patients are actually diabetic patients, and you can look at the HbA1c also coming down as well. And those who are not on GLP-1 after the surgery, some of them the HbA1c is going up, right? And what surgery they do, they are not doing the surgery that I did. They only do sleep only and RIGB, right? So I already spoke so long already, right? So I must show you some example. So how do I use it? So one of the lady, 26 years old, college student, she has a childhood obesity. BMI came to me at that point of time is 42.3, and she had tried multiple dietary programs. Okay, what you can think of, you name it, she has it already done before, and always failed, right? And she also tried GLP-1 injections before, so I think 3 months. After the injection, already no money already, then really down after stopping, right? So he came to HBHK, came to me. So, but I don't just do surgery straight lah. You have to go to my dietitian, go to my physiotherapist and all. Then we decided to do a sleep PJD, right? And she can be discharged after post-op 3 weeks. This is before, and this is with permission. The before BMI was 42.8. Then this is 5 months after, 35.8. And she said she want to change her clothes. She want to start buying clothes. I said, stop first. Because if you're going to buy now, after 9 months you're going to buy. Yeah, so better it's okay. Just a college student, nobody. I don't know she has a boyfriend or not, but said stop first, save some money first. Okay. And I would like to introduce body impedance analysis. Right? This is what my favorite. Okay? And the BIA machine, and I've been fighting in Guam already. Right? As you know, I'm sorry to say. But the machine is not the black color one. The machine is the white color one. Okay. The black color is just a technician. Right? So after you put on the machine, And what I mentioned, BI machine, because last time I was with TWG with Dr. Arif and Prof. Rana as well. Somebody, I forgot in a big group, somebody said BIM machine is just a scale, it's a scaling machine, it's a weight scale. But mind you, it's not. BIM machine is not a weight scale, right? Because it will tell you the fat mass, muscle mass, the total body water, and also the bone, right? So after you put on that, this is what I want. So you can see everything already, right? And overall weight is very yesterday, so we don't look at overall weight anymore because it can reduce the muscle mass. So what we are looking at is the fat mass. More specifically, is the visceral fat. The visceral fat, if you have a better model, I can even look at the visceral fat, right? Okay. So you look at this chart. This is the patient chart, and you look. You see, I don't cut her straight. If I cut her straight, then it will be here already. I want her to suffer. Okay. 1 is 1 month, right? 1 is 1 month. So when she already cut police, 103.9 already. Alright? But if you look at this, actually this one is quite nice. Why? Why? Even though the weight increased, but I praise her, because the weight increase is not really the fat, She actually increased the muscle. You want to increase 100 grams of muscle, you need a lot of effort. Alright? I'm in KKN, right? My service is free. And they are still asking discount from me. I say, Ken, I discount 100% because my service is free. It's still zero. Right? So this after I do this, at the 4th month, like the first month, this is first month, this is first month, then this is 4th month. Actually, she'll see at 3rd month, but there are some issue, obviously issue. So she came at 4th month. And then you can see the weight reduction is about 15.2% already. Right, that's overall weight. But the fat mass reduction is 12.5. I'm not satisfied with me. I'm not satisfied because she lost a lot of muscle. Right. If let's say you don't have BIA machine, you just look at it, wow, cantik, bagus. Right? At this 4th month you say it's very good, but actually it's not good. It's not good at all. Right? She lost a lot of muscle. So I go back and question her. Right? Usually I don't do this because the one who question her will be my MO. That is the perk of being KKN. Right? You don't do everything yourself. So we noticed she didn't exercise properly, even though my physiotherapist really, tekan already. And she had this sweet tooth, and she's so stressed, and she started to take all this sweetened coffee, right? And really, so the next step, this is what I start. But I start on this, and reinforcement on the exercises. Right? I'm not sure because of the exercise or because of the medication, right? But 5th month, I see her the next month, right? You can see the total weight reduction. The 1 month is 3.4 is still on the path, right? But one thing what I can see is actually the muscle mass. The muscle mass start to reduce a little bit, right? So this is the comparison. At 4th month, you can see this is per month, right? Because if I want to compare, only per month this year. But for month, you'll see even though this is actually more than this, right? But you must understand this total weight. Total weight comprises the muscle. So you look at the muscle mass, right? It's reduced 300 grams only, but this one every month she reduced at least 800 grams. Which is a lot, right? She's going to be sarcopenic if I don't do anything, right? But the fat mass reduction is about the same per month. So she still maintained it, right? So preoperative use. Preoperative use, do I use it? Sometimes, like endocrinologists refer to me, I love it, because everything has settled already. I just need to ask, bayar tak? But for those others who just came, because my clinic actually they can walk in, I have no issue. Alright, as long as your BMI is high, you want to lose weight, you just come in. But I'm not going to cut you straight up, right? Of course, you have to go to my Nemo, okay? Right? So the pre-operative use, let's say all those patients, those are not big prime, right? I can use it, but from the perspective of the surgeon, it's not really to reduce obesity, but actually bringing you towards surgery, so it can reduce the fatty liver. Fatty liver is very notorious among bariatric surgeons, right? For bariatric surgeon, afraid of two things. The first thing is the wife. The second thing is the fatty liver. Not really. Alright, I can only speak for myself. Alright, so to reduce the fatty, because if your liver is fat, the fatty liver, we are going to manipulate the stomach, right? It might bleed a lot, right? And bleeding is actually something not great, right? And also to reduce the momentum mass. You look at the momentum, you might see, because we are doing oral laparoscopy, right? You know fulcrum, right? Just a little bit of fat, you feel so heavy. It's very heavy. So when it's so heavy, and you look at me, I'm also quite obese already, right? So you see, it is going to be my gym, but I can just reduce the fat mass. Usually, how I use it is I just give at least 1 month. My favorite is GLP-1. If the patient can afford GLP-1 1 month, then we bring to surgery, and actually can reduce both of it. And to reduce overall weight, okay, the problem in a small hospital like Guam is the OT table. My OT table can only go up to 130 kg, even though there are promises that can bring the 300 kg to my OT, but promise is a promise. So I have to bring, instead of bringing the OT table, so I have to bring the patient to my existing OT table, right? So that's why there's a limit. That's why the surgeon from Moa also keep on asking me, you know, so why you have limit for your patient? It's because my OT table. Right? You can go to my private practice. Okay, but the patient weight is too high, unable to be handled, so you can use GLP-1 or you can use your medication, right, to reduce overall weight. And it may improve glycemic control. My NS will learn this. Right? GLP-1 also can improve the glycemic control. Right? So conclusion, MBS is still the most effective way. Yeah. Alright. Then I would like to introduce that MBS is actually a hormonal surgery, right? Because it's altering the neurohormonal status rather than volume mechanical. Then the main issue is the weight regain post surgery, and it's useful for pre-operative operation, right? So if you cannot get enough of me, then you can come to Mugis, right? Mugis will be in the Bansa. Sorry, from promote skip. Right, okay, so thank you.